Hi guys, welcome to podcast 19 of Let's Revise MBBS, and our today's topic is very interesting, which is fetus inside the uterus. So first, I'll talk about the basic terminologies which we use to define or to locate how the fetus is inside the uterus. So the 6 terms are lie, presentation, presenting part, attitude, denominator and position. Okay, so what is lie? It is the relation of the longitudinal axis of the fetus to that of the maternal spine. Okay, so we have 3 basic lies. The first one is longitudinal lie, where the vertical axis of the fetus corresponds to that of the maternal spine. We have second one is transverse lie, where the axis of the fetus is perpendicular to the axis of the maternal spine, and oblique is anywhere in between. Anywhere between perpendicular to parallel is oblique. Okay, so most of the times, 99% of the times, the lie is longitudinal, but rarely it can be transverse or oblique. So if the lie is transverse or oblique, we can try external cephalic version. That is, we try to rotate the baby and try to bring it in the longitudinal lie by externally rotating it. Okay, so we can do this at around 36 to 37 weeks. If we do it very early, then the baby might go back in the transverse lie. So we do it at 36 to 37 weeks. But we can also do it till the latent phase of the labor. Okay, we'll talk about various stages of labor in the next podcast. So, but we cannot do this if the patient is in active labor. Okay, so we saw about the lie. Now let's come on to the next term, which is presentation. So presentation is that part of the fetus which occupies the lower pole of the uterus. Okay, so if the lie is longitudinal, then presentation can be either cephalic presentation or breech presentation. Okay, if the head is occupying the lowermost part, then we call it cephalic presentation. If the sacrum or the buttocks area is occupying the lowermost part, then we call it breech presentation. Okay, in transverse lie, we can have shoulder presentation. Okay, and there's one more presentation, which is compound presentation, where more than one part occupies the lower pole of the uterus. Like for example, head as well as the hand or the elbow can occupy the lowermost part. Okay, so that presentation is called as compound presentation. Now moving on to presenting part. Before doing that, let's imagine fetal skull. Okay, now let's divide the fetal skull in 4 parts. Okay, so anteriorly we have the face and nose. So just above the nose we have a ridge. Okay, just above the nose. That's the first part. Then the second point is the anterior fontanelle, which is diamond in shape and which is also known as bregma. Okay, and the third point is the posterior fontanelle, which is triangular in shape and it is known as lambda. Okay, so 3 points. A point just above the nose, then the bregma and lambda. So these 3 points divide the fetal skull in 4 parts. Okay, anything below the nose, below the upper part of the nose, is face. Okay, the area between the upper part of the nose till bregma is brow. Okay, area between bregma and lambda, that is anterior fontanelle and posterior fontanelle, is known as vertex. And anything below the posterior fontanelle or below lambda is known as occiput. Okay, so these are the 4 parts of the fetal skull. Now let's talk about presenting part. So presenting part is the part which is closest to the internal os. Okay, so it depends on how the attitude of the fetus is. So if the head of the fetus is well flexed, then the presenting part is vertex. Okay, if it is partially extended, then the presenting part is brow, and if it is fully extended, then the presenting part is face. Right, as we go on extending, the presenting part comes from vertex to brow to face. Okay, now let's talk about various attitudes and various diameters involved in different attitudes. So mainly we have 4 attitudes. The first one is well flexed, then deflexed, then partially extended and completely extended. Okay, so let's see various points on the back side of the fetal skull. So lowermost point will be below the occiput. So that point will be known as subocciput. Above the subocciput, we will have occipital area, right? Occiput. Above the occiput, we will have vertex. And above the vertex or anterior to the vertex, we will have bregma, right? So now if you remember this, or if you understand this, it's very easy to remember which diameter will be involved in the respective type of attitude. Okay, so if the fetus is well flexed, then the diameter involved will be suboccipito-bregmatic. Okay, suboccipito-bregmatic. It measures 9.5 centimeters. Now if the head is deflexed, okay, deflexed is partially flexed or no flexion, no extension, so deflexed. So if it is deflexed, then the point will shift upwards from subocciput to occiput. So the diameter involved in deflexed position is occipito-frontal. Okay, occipito-frontal. It measures 11 centimeters. Now if the head is slightly extended, okay, partially extended, then the point will shift further upwards and it will shift from occiput to vertex. So the diameter involved, or diameter in partial extension, is vertico-mental. Mentum is chin. So vertico-mental. That is the largest diameter, which is around 13.5 to 14 centimeters. Okay, and if the head is fully extended, then the point will shift further anteriorly and it will go to bregma. So the diameter involved in full extension is submento-bregmatic. Okay, below the chin to bregma, submento-bregmatic. It also measures 9.5 centimeters. Okay, so 4 diameters we saw in 4 different attitudes. Let's revise. Completely flexed, we have suboccipito-bregmatic. Deflexed, occipito-frontal. Partially extended, vertico-mental. And fully extended, submento-bregmatic. 9.5, 11, 13.5 and again 9.5. Okay. Now let's talk about denominator. So denominator is a bony point on the presenting part which is coming in contact with the pelvis. Okay, it is a bony point on the presenting part, right? So now we have seen various presenting parts. So the first one was vertex. If the head was fully flexed, then the presenting part is vertex. So in the vertex, the point which comes in contact with pelvis is occiput. Okay, so in vertex if the presenting part is vertex, then the denominator is occiput. If the presenting part is brow, then the denominator is frontal eminence. And if the presenting part is face, then the chin comes in contact with pelvis. Therefore, in mentum or in face presentation, in face, the denominator is mentum. Okay, so that was about denominator. Now coming on to the final term, that is position. Now these positions are very easy. Let's now just imagine that the mother is lying in the labor room, supine, is placed supine and her thighs are flexed, and you are seeing the cervix or the head of the fetus from the leg side. Okay, now imagine a clock there. Okay, and we'll divide this in 8 parts, right? So now at 12 o'clock, if you see it, there is pubis of the female, pubis. Okay, and at 6 o'clock it is sacrum. Okay, and whatever is your right becomes the female's left. Okay, and vice versa. Now since the most common presentation is cephalic presentation, and in that vertex is the most common presenting part, and in vertex occiput is the denominator, so we will talk about positions with respect to occiput. Okay, so at 12 o'clock we have occipito anterior position. Okay, because it is anterior, right? Pubis is anterior. So at 12 o'clock we have occipito anterior position. At 6 o'clock we'll have exactly opposite, which is occipito posterior. Easy, 12 and 6. Now let's talk about 3 and 9. So 3 o'clock is at your right, but it is female's left. and it is transverse position. So it becomes, the 3 o'clock becomes left occipito-transverse and 9 o'clock becomes right occipito-transverse. Okay, so we talked about 12, 3, 6 and 9 position. Now let's talk about 1:30 and 4:30. 1:30 is towards the left side, right? You're right, but patient's left, and it is also anteriorly. So that position will be called left occipito-anterior. And 4:30 is also towards the left, but it is posteriorly. So that position will be called left occipito-posterior. Okay, similarly 7:30 is posterior but to the right, so the position will be right occipito-posterior, and 10:30 will be anteriorly but to the right of the patient, so it will be called right occipito-anterior. Okay, so these are the 8 positions. Right, now which is the most common position of the fetus? It is left occipito-transverse. Okay, it is also the most common position at the inlet and during the early labor, that is left occipito-transverse. Okay, if the occiput is present anywhere in the posterior part, that is right occipito-posterior, occipito-posterior or left occipito-posterior, then that is known as malposition. And the most common malposition is right occipito-posterior. Okay, right. So you need to understand the difference between malposition and malpresentation. We have talked about presentation. So breech presentation is malpresentation. Okay, it is not malposition. Malposition is anything posterior, like right occipito-posterior, occipito-posterior, left occipito-posterior. Right. So that was about 6 terms commonly used. Now coming on to the last part, which is Leopold grips. So we have 4 Leopold grips to assess the position or to assess the shape, or assess how the fetus is inside the uterus. So the first 3, for the first 3 grips, we stand to the right of the patient and we face towards the face of the patient. Okay, and for the 4th grip, we face towards the foot end of the patient. Okay, so Leopold grip 1 is also known as fundal grip. Okay, where we try to palpate the fundus of the uterus with both the hands. Okay, so what will be the most common structure felt there towards the fundus? Obviously cephalic, obviously breech, right? Because the most common presentation of the fetus is cephalic presentation. So breech will be at the fundus. So we will feel the breech part, which will be broad, soft and irregular. That is Leopold grip 1. Now Leopold grip 2 is known as lateral grip. Okay, so we come below the fundus and try to palpate the parts of the fetus. Okay, so can you tell me what is the structure that will be felt in the left lateral part? Right, back. Why back? Because the most common position we saw was left occipito-transverse. That means occiput is present on the left side. If the occiput is on the left side, even the back will be on the left side commonly, right? So left lateral position, we will feel the back, and on the right lateral position or right lateral part of the uterus, we will feel the limbs of the fetus. Okay. The third grip is known as Pollick's grip, which we do with one hand. This is the only grip done with one hand, and we see if the head is ballotable or not, if we can move the head side by side or not. If we can, then it means that the head is not engaged. Okay, and if we cannot move it side by side, that means the head is engaged. Coming on to the last grip, which is grip 4, which is known as deep pelvic grip. Okay, so here with both the hands, we try to point the fingers towards the pelvis of the female. So if the hands are converging, that means head is not yet engaged, head is floating. Okay, and if the two hands are parallel, that means the head has engaged. Okay, so what do you exactly mean by engagement? When the largest diameter of the fetus enters or crosses the pelvic brim, then it is known as engagement. Okay, so we have talked about anterior-posterior diameters, the 4 anterior-posterior diameters. transverse diameter is biparietal diameter, which is the largest and which measures 9.5 centimeters. Okay, so if this biparietal diameter crosses the pelvic brim, then we say that the fetus is engaged. Okay, so the station is 0. At station 0, we say that the head of the fetus is engaged. Okay, and the station 0 is at the level of ischial spine. Right? So that's it for today's podcast. We talked about the 6 main terminologies that we use to define the position or to define how the fetus is lying in the uterus. And then we talked about the 4 Leopold grips and something about engagement. Right? So that's it. Keep studying and enjoy. We will meet in the next podcast. Bye.